Welcome and thank you for joining us for this presentation for the social marketing module. Today we'll be analyzing the COAST campaign, which stands for Chlamydia Outreach, Advice, Screening and Treatment. Myself, Valeria and Arjun, we will take you through a detailed analysis of the campaign. So, what's the purpose of the campaign? Chlamydia is the most common sexually transmitted infection in the United Kingdom, with a higher rate infection in women compared to men, especially among young people between 15 to 24 years old. The campaign was launched in 2007, and it's a nurse-led project developed under the England's National Chlamydia Screening Programme, and it was run in the Northern Lincolnshire. The objective was to increase chlamydia testing rates among this group of people and to achieve government targets of 35% minimum screening rate. So the problem identified, as I previously mentioned, is that chlamydia is the most common sexually transmitted infection in the United Kingdom. And in 2023, there were around 401,000 cases of STI diagnosed in the UK, of which around 48% were chlamydia. The mission of this campaign was to increase testing rates and create more awareness around this problem, but mainly to achieve the government target of 35% minimum screening rate among this group of people, 15, 24 years old. The scoping was essentially that at the time, Northern Lincolnshire was failing to achieve these government targets, hence why the campaign was run. In social marketing, we refer to stakeholders, people that are directly and indirectly involved in the campaign and can also contribute to the development of the marketing objective. As you can see on the left-hand side, we have the main stakeholders. You can read through them. The main ones obviously are the group of people that were targeted for this campaign, which is 15 to 24 years old. But we have also third parties such as pharmacies, football clubs, colleges, and so on. On the right-hand side, we have a matrix of stakeholders, which is essentially divided into four groups based on level of interest and power. For the COAST campaign, we have applied the health belief model, which is a psychological framework developed in the 1950 in the US, which helps understanding and explaining change in health-related behaviors, particularly to explain the failure of people to participate in programs to prevent and detect diseases. The health belief model contains several concepts that predict why people will take action to prevent, to screen for, or to control illness conditions. And he states that individuals are more likely to take preventive actions where they are susceptible to a condition. The COAST campaign is an excellent example of the health belief model in practice. As you can see here, we have a table on how the COAST has addressed each of the concepts in the health belief model. We have perceived susceptibility, the perceived severity, perceived benefits, perceived barriers, self-efficacy, and cue to actions. Each of them have been applied in the COAST campaign. Unfortunately, because of time restrictions, I won't be able to take you through all of them, but please take your time to pause the presentation and read through them. In order to understand the external factors that might influence the campaign, we have applied the PESTEL analysis, which is a systematic framework used to address these external factors, such as political, economic, sociological, technological, legal, and environmental. Again, I don't have much time because of time restrictions, so please feel free to pause the presentation and read through each of them. Lastly, to understand the internal factors that might influence the campaign, we have applied the SWOT analysis, which stands for weaknesses, opportunities, and threat. And it's a business tool that evaluates how company compares to its competitions. So how does the Coast campaign differentiate itself from the other competitors? It's essentially a community-based delivery campaign with a lot of branding and extensive local partnerships, which obviously differentiate itself from clinic-based and private testing options.
Hello, everyone. We now want to look at the competitive environment in which Coast operated. So we analyzed two major national campaigns. The sex we're talking about campaign ran from 2009 to 2010 with a £6.7 million budget. Its main aim was to normalize conversations about sexual health and influence preparatory behavior, in particular acceptance of chlamydia screening. The campaign employed TV, radio, billboards, and a dedicated Facebook page to stimulate discussion among 15 to 24-year-olds. The campaign succeeded in sparking dialogue, but its short duration limited sustained behavioral change. Critics also noted that comments on social media were not always supportive, and there was no monitoring of offensive content. This lack of a safe environment likely limited its behavioral impact. The campaign was part of the wider National Chlamydia Screening Program, which provides the national structural framework for chlamydia screening. Despite £150 million invested between 2003 and 2009, screening rates remain low, with only 5% of 15 to 24-year-olds tested in 2008, against the 15% target. At the time, key inefficiencies included fragmented local procurement, which produced uneven service quality and limited access. The program also lacked mechanisms to measure infection reduction, and young people rarely received safer sex advice when tested. Moreover, the absence of a national website or brand identity weakened delivery. So the Coast team entered this environment with clear and measurable objectives aligned with national expectations but tailored to a local context. The program aimed to screen 15% of 15 to 24-year-olds in northern Lincolnshire in 2007, increasing to 17% between 2008 2009, 25% between 2009 2010, and reaching 35% by 2011. Unlike national programs, Coast embedded evaluation into its design, ensuring progress could be tracked against measurable outcomes. The primary target for the Coast campaign was sexually active men and women aged 15 to 24 in northern Lincolnshire. Research indicated particularly low uptake among males, a gap that national campaigns and the NCSP had not effectively addressed, making this group particularly vulnerable. In fact, the NCSP is focusing on opportunistic screening for women only. The program also identified screening sites such as GP surgeries, youth centers, and sports venues as a crucial secondary audience, as their participation was essential for reaching the primary group. To ensure that the campaign will reach its target audience, barriers to change were analyzed. These are divided into four categories. Situational barriers included perceptions of screening as expensive, inconvenient, and embarrassing. In Coast, this was addressed by offering free testing and treatment at convenient locations and times, and guaranteeing complete discretion. For providers, barriers such as heavy workloads and competing priorities were reduced by simplifying logistics. Coast simplified screening for frontline staff by managing treatment and follow-up directly for positive cases. Knowledge barriers reflected low awareness of service locations and possible language challenges. Therefore, Coast organized outreach activities and tutorials delivered at local schools to educate students on what a chlamydia test is, where it is offered, and why they should get tests. Moreover, the do-it-yourself kits were illustrated with a step-by-step guide. Behaviorally, many young people worried about others discovering they had been tested. Coast made the contact as private as possible by notifying test results through text messages that use clever statements like "the coast is clear." Attitudinal and motivational barriers included fear of a positive result and discomfort in informing partners. Coast addressed this by helping tracking down and informing any previous sexual partners and encouraging them to be tested for chlamydia as well. Coast's ability to change behaviors lay in its attractive offer, structured around the 7 Ps. First of all, we look at product, which consists in free screening and treatment, do-it-yourself kits, and supportive operations delivery for frontline staff. For example, practice nurses would be provided all the necessary screening tools in just one bag. Price for product, well, testing and treatment were completely free with flexible treatment options, plus offering user-controlled process, removed emotional and practical barriers. For place, the testing and treatment was offered in over 100 sites in both clinical and non-clinical environments, plus online and text-based ordering service expanded the convenience. We looked then at promotion. Coast employed branded posters, radio ads, alongside incentives such as P for Pens and We for a We. Screening sites were also incentivized in delivering the program, and the top performing centers could win free attendance to the NCPS conference. For participation, do-it-yourself kits empowered young people to test privately, reducing stigma and embarrassment while increasing autonomy. For partnerships, in addition to working with local institutions and service providers, COAST also formed partnerships aimed at directly reaching the young men. Collaborations with local football teams helped normalize screening by embedding it in a familiar community setting. On match days, players wore Get Your Tackle Test t-shirts, while volunteers engaged with fans, adding credibility and reducing embarrassment by presenting testing as a socially accepted behavior. Last but not least, we have positioning. The Coast brand was a youth-driven brand. In fact, they use focus group just to choose how the brand will look, ensuring resonance and consistency with the target audience.
Coast Campaign developed its offer using the health belief model. Coast was a nurse-led sexual health program in northern Lincolnshire for young people aged 15 to 24. It offered free, private chlamydia testing with postal do-it-yourself kits, quick result by text or email, and support for partner notification. The campaign's message focused on awareness, explaining that chlamydia is often symptom-free but can cause infertility if untreated. It promoted benefits such as peace of mind and convenience, while reducing barriers like embarrassment and fear by using humor and youth-friendly branding. Slogans like "Get Your Tackle Tested" and "V for V" help make testing for normal, approachable, and even fun. This simple, trusted design encouraged more young people to test and talk openly about sexual health. This part focuses on partnership and collaboration. The campaign worked closely with schools, colleges, gyms, football clubs, pharmacies, GPs, and youth centers to increase reach. These partners hosted on-site testing events, displayed posters, and promoted testing through everyday conversations. Youth workers, salon owners, and sports coaches acted as informal ambassadors, showing that testing was safe and acceptable. This network of partners reduced social barriers and built community trust, turning chlamydia testing into a normal, supported behavior instead of hidden one. To recruit participants, nurses visited youth sport venues and used humor to spark interest and reduce stigma. Testing was offered in two ways: on-site through private rooms and take-home postal kits with district packaging. Each sample was tracked using barcodes and results were delivered in less than 8 days. For positive cases, nurses personally called patients, arranged treatment quickly, and guided them through partner notifications. A data analyst monitored live statistics such as weekly results, venues, and demographics, ensuring efficiency across areas. The campaign's performance was monitored through the National Chlamydia Screening Program system. Data were collected on kit distribution, test returns, age and gender breakdowns, and laboratory turnaround times. Nurses also reported privacy issues, messaging feedback, and attendance trends. This continuous tracking helped the campaign identify the most effective venues and refine its outreach each week, keeping delivery efficient and evidence-based. The outcomes shows clear progress. Screening coverage rose from 7.5 to 26.4%, surpassing the national target of 25%. All positive cases were treated a 100% success rate. However, partner notification remained low at about zero point 0.4 partners per case, showing emotional barriers still existed. Retesting behavior wasn't measured, meaning long-term impact on reinfection couldn't be fully assessed. Still, the data confirmed that COST successfully improved awareness, access, and trust among young people. This part shows how the campaign worked across three system levels. At the macro level, it changed individuals, increasing awareness, motivation, and confidence through nurse support and friendly communications. At the meso level, it shaped communities, using schools, gyms, and salons to make testing a shared socially accepted norm. And at the macro level, cost aligned with NHS policies, national funding, and data standards, embedding the project within wider health system. Together, these layers created a coordinated approach that influenced individuals, communities, and public health structure. Finally, the campaign's recommendation aimed to strengthen future success. First, focus on engaging young men through football apps, TikTok, and influencers to normalize testings. Second, promote emotional benefits like peace of mind and relationship trust, not just disease prevention. And third, continue offering mobile clinics and postal kits for privacy and easy access. By applying these ideas, future campaigns can build on cost achievements and further reduce barriers to sexual health testing.